Hi, everyone. I'm Jamie from 3Terra. We would just like to start by thanking all of our speakers as well as our attendees across the country for their time. We understand everyone is busy and we are truly grateful to all of you for attending. Today, we have over 50 hospitals joining us. Although the DQA platform began as a health records tool, it has expanded over the years with your continued feedback and is now being used by over half of the hospitals in Ontario. More now than ever before, decision support teams are leveraging the platform for enhanced reporting, the creation of insightful dashboards, and the deep dive of analytics. In recognition of this shift in usage, we are proud to present our first innovation center dedicated to the decision support community. To be courteous to our speakers and avoid background noise, we have muted everyone's microphones. We ask that only the speakers turn on their cameras and mics for their sessions. We are happy to take questions and comments in the group chat, and we will be monitoring this and taking them in the question and answer periods after each session. By request from many that were unable to attend, you will have received a notice that the session is being recorded. If you would like a copy of the video, we will share this upon request, so please feel free to reach out to us. For our first session, Matt will walk us through some key features in the DQA platform that may not be known to everyone. In lieu of a Q&A session, we ask that anyone interested in learning more about these or other DQA features reach out to us directly so we can schedule some time with your team. For our second session, we have Sunil Nair joining us from St. Joe's Hamilton. He will be sharing some examples of how he and his team have applied the reporting available through DQA to support their work. Third, we have Carly Archer and Jennifer McCallum joining us from London Health Sciences to share how they analyze their hospital's emergency department using the 3Terra platform. To conclude the hour, Matt will be speaking about the future direction of analytics at 3Terra, and we'll show a few examples of what's to come. At the end of the event, we will have a slide with the contact information for all of our speakers, so please feel free to reach out to them directly. So to begin, we have Matt Gertz to highlight 3 essential tools for analysis in DQA.
All right. Good morning, everyone. Thanks for joining us. I'm just going to try and share my screen here and walk through some kind of core features in DQA that are being used by hospitals across the province as foundational tools for decision support teams in the platform. The decision support features that have been in the tool have been kind of incrementally added over time. And over the past few years, they've matured a great deal. So, as a preamble to what St. Joe's Hamilton and London Health Sciences are going to talk about, I want to make sure that everyone kind of has a common understanding of the baseline of the tools that are available in DQA that these hospitals are leveraging. So there are 3 main tools in DQA that are worth talking about here. And they are the reporting engine, direct database access, and indicator management. And I'm going to talk about each of these in a little bit of detail. So first, let's talk about the web-based reporting engine. As everybody knows, Data Quality Assist allows health records to review cases for data quality reasons. But more than that, it's a web-based tool that allows you to also explore the same data. So the NACRs and the DAD data that we bring in, along with other supplemental sources, are available for you to query and navigate and use in the web tool to answer questions that you may have. And many hospitals are using this in different ways to answer ad hoc queries that come up. And let me kind of give some examples of this. Using a report like this as a starting point, you have the ability to come in here and add different filters to this report. So if I want to see the number of hip fracture QBPs that Dr. James Smith has completed so far this year to date, I can add filters to this report that will allow me to query that information. I can also add different fields that are available in the tool for analysis. So if I want to look at how many of these patients experienced hospital harm, or how many conservable days do we have, or things like that. You can add additional fields into the report to create essentially a custom report that's going to answer a question that you might have. And then once you've got a report that is of interest, you want to be able to distribute it. So as many of you have found, you've got a number of different ways to distribute information. You can export the data, which will essentially download the information as a CSV file, which you can open in Excel and use. If you're creating a PowerPoint presentation and you're showing trending of hip fractures for this doctor over the past year, you might want to export that and use it in a way like that. You can also publish or bookmark reports. And this is more commonly used when you create a report that you'd like to send over to finance so that they look at it once a quarter, or you want to come back to later on this year to look at it for some particular reason. So through the bookmark functionality, I can save the definition that I have created to distribute to others, but also to use going forward in the future. We know that accessing all of the information that we have in our system through the web-based interface is not enough. So for the crowd that we're talking to today, you want to be able to access and query that data in a more sophisticated way, answer more complex questions. And so something that we've added, I would say, within the last year to 18 months is the ability for you to access all of the same information that's available in the tool through the web interface, through your browser, but through the database directly. And this is because our system resides on site at your hospital on a server there. So we've exposed database views that allows you to connect directly to the database and query that information. So a couple of use cases that you would care about is, we had a hospital come to us last year and say, I'm getting a request from executive leadership. They want to know which physicians are using a particular type of equipment for the interventions that they're doing. That's something that would be hard to do through the web framework, but is very easy to do through a relational database query through the database views that we've got here. So a more complex ad hoc query that you might want to look at. A lot of hospitals have also said, I'd like to take the data that you guys have, in particular the calculations that we're doing, things like QBPs and GI endoscopies and cardiac procedures and hospital harm and many others. The hospital isn't interested in continuing to calculate those things manually and maintain them as they change year over year. So a lot of hospitals have decided we're just going to use this database as a data source to pull information from the DQA database into their own data warehouses or data marts that they're building to kind of reduce some of the burden on their team on an ongoing basis. And then I know something that Sunil is going to talk about in the next session is using this data as a source for reporting directly. So, creating new reporting services or crystal reports to answer certain questions, or integrating it into the analytical engine of your choice, be it Click or Tableau or Power BI, to use this as a data source for quickly creating analytics to answer questions for the hospital. So this is something that, again, is relatively new. I'm not sure that everybody is using yet, but those that are using it are finding a lot of value and benefit here. And then the final one that I'd like to talk about is indicator management. For a long time, we have calculated a bunch of public indicators on hospitals' behalf. So I mentioned quality-based procedures and GI endoscopy and hospital harm. There are many others that we have decided to implement because otherwise it's a burden on hospital decision support resources across the province. Given that everyone is calculating the same things, if we build it once and everybody can benefit from it, I think it makes a lot of sense. And we go through our reconciliation process so that you don't have to worry about that and you can trust the numbers. What's new here within the last 6 to 8 months or so is that we've opened up this interface for developers to be able to create your own custom indicators. And I know, a couple of the speakers today are going to talk a little bit about this, but if you, as an example, had a particular patient population that you wanted to calculate, you can implement a stored procedure, a very simple stored procedure that would say, show me my high-risk C-section births. show me my mental health patients that meet a certain criteria that's custom to me and different from someone else, or flag patients that meet certain criteria that I want to analyze in further detail. And this is important because when you implement it, you can then use those calculations either in the web-based reporting framework or in the database views. So you can access that information either way that you want it and analyze it in either direction. So these are the three kind of primary foundational tools that are worth knowing about, and I think worth having kind of a common understanding of as St. Joe's Hamilton and London Health Sciences talk about some of the ways that they've put this into practice. So I'll pass it back to Jamie and let Sunil get started with his presentation.
So in lieu of a question and answer period here, we do ask that you reach out to us directly so we can review any of these items or other DQA features that you would be interested in learning about. Up next, to highlight some of the features that Matt spoke about and to share his experiences, we have Sunil Nair joining us from St. Joe's Hamilton.
Thanks, Jamie. Thanks, the team at 3Terra for giving us the opportunity. But before I begin, let me say a big hello from St. Joe's Decision Support team to our colleagues out there. I can see a lot of names that some of them I do recognize, so it's good to meet you guys again online. So having said that, let me make sure that I'm able to share my screen. Please let me know if it comes up or something like that. Jamie, just let me know if you can see my screen.
You are good.
Okay, great. Okay, so here we go. So that's, I thought I'd start off by just, giving one slide to say how we are different from a lot of the other organizations. So as you know, St. Joe's is a teaching hospital in the Hamilton area. And even this was a surprise to me when I first came in and joined, we looked at the total number of beds. We are, 975 beds. That's a big hospital. But if you look at here, the key that I just wanted to point out from this slide actually is the 422 mental health and addiction beds. So that just shows you right off the bat that our 50% of our business is mental health. That's totally not acute care related. So what we're going to talk about today is how we are using the tools for the rest of the 50%. And that's where all the funding is, right? So it's very, very, very important information that we, right off the bat, I want to share with our leadership, for example, to say, hey, we are looking at all of this data, and we're talking to you on a daily basis, sort of, the CMIs and the Higg-weighted cases and all of this. And that's just 50% of our business. So that was one of the first things that I just want to highlight and point out as far as how different we could be to some of you out there who are more acute care, in terms of their business, right? So that's that. The next slide that I wanted to show you here is, let me just make sure I have it all set up. Okay, to give a little high-level idea of what the team is. So corporate decision support, we report up to finance, to CFO. Under corporate decision support, our director, we have two departments. Us, of course, with case costing and coding. So that's where we are placed within the organization. Within the decision support team, we are a small but lean and significant team of 5 people, and that includes the director. So it's a working director, right? And so that's how small we are. And it's very significant when I highlight that point here, because that's where 3Terra adds value to our team, right? Because it would be impossible to do the kind of work that I did in my previous life, working in another hospital, where we had no support in terms of tools like this. It would be a totally different ballgame. And also one point that I missed in introducing here, it was the hospital system that we are on. We are on Epic system. And so we were one of the pilot hospitals to go ahead with this in Canada, right? And so it's quite mature at this point in time in terms of a lot of the operational reporting and day-to-day volumes or ED visits and the length of stay average, what's going on. A lot of those are directly available in terms of dashboards and reports that the physician chief of emergency, for example, or the director is able to get. So a lot of the operational and just around volume piece or the wait time pieces are all available to them. And we don't get into that a lot. So that's how the team is also a little bit different from some of the other teams out there, at least the ones that I've worked in the past, which was that those kind of questions would come to us. And that would take up most of our time. So suck up all our time and energy. So we are just looking at day-to-day firefighting, basically, right? So that's where we were in my past life, at least. So now here, what I see is you have the small team, but very core, significant team. One of the team members looks after our case costing area, basically. The director, myself, and we have 2 vacant. Obviously, now we're trying to hire some people. And we also have another team member who does our data analysis. So that's us. We work very closely with our coding team. The manager of coding, works very closely with us because she used to be part of our team and now managing the coding team. So that's who we are. Back to our partnership. Just a little background. So we are very, very new with the partnership. It's only 2 years in, so we're just starting to learn and use, in the sense, more effectively for our use, and then having some kind of plan for the future to, use Tritera tool for to basically what Matt talked about earlier, because now we have access to the backend and the database, so we can actually try to link it to our reporting tools and our internal, databases, and then, try to see what is possible. I already see a question come up in the chat about case costing data, right? So that's where all these potential lie, where we can use that and this data, for example, externally, not within the tool, but within our own database, and then do some stuff and reporting from out of there. So just 2 years in, and what I have here to show basically is how we have initially, basically socialized the Tritera and what it does to our senior leadership team, and whenever we got a chance. So we would show something like this and say, hey, look, because the data, as part of a decision support team, all that we hear for a lot of time is, something doesn't look right, or data is probably not wrong, or the data is wrong, or go back and look at their numbers, or things like that, right? We get a lot of different comments. I don't have to go there, but you all know what I'm talking about. So we wanted to make sure that people understand that there is a team of coders who go through the rigor of doing the data quality to begin with. And then we have this engine who is running the data and then giving us that, making us much more efficient and improved. And that's what goes into Kai-Hi, for example. And then that's what the decision support team would pull out. And that's the report that you see. So what goes in has gone through a rigor of data quality assurance. And that's what we wanted to show. And as an example, the first year when we joined with Tritera, they gave us a report at the end of like 6 months or some. They took the existing coded data that we already had, ran it through their engine, and found that we could improve our weighted cases by 1%, slightly more than 1%, which was great in itself, that we already were doing a good job. But now we have used this engine, the powerful engine, to ensure that we are doing even better. So it really went well. That messaging really went well with our senior leadership team. So that's just want to highlight that as a point. Back to that, the whole, the gist of our conversation today that I would like to focus on is basically this. What I mean by that is everything begins by trust. So what I mean by here also is, even from the leadership's point of view, so our team is blessed, I should say, in a way that we do a lot of those strategic reporting. So if our executive lead, for example, leadership team have a question, they know who to go to. They come directly to my director. His name is Ravi. Don't know if he's actually attending today, but he probably is. But they would go to Ravi and say, okay, can you give me an answer? They're probably sitting or going into a media call. They're probably sitting around a table, and then they're asking this question, but they know who to go to, and they would come to the source and then ask that question, whatever they have to deal with on that given day. So that took a little bit of an effort to get there. And I just have listed 3 things. I'm sure there are more, and everybody have their own way of doing this, but I just have listed a few on the screen here, where, I'm just saying that what we all do. We're trying to give evidence to support their decision now, right? So sometimes we take data to them and it doesn't make sense to them, right? So now we are telling them, okay, these are the things that are happening around the organization, and they sometimes pay attention, sometimes they get it, sometimes they don't. and then things go in a circle. But now here, the difference is now they have made a decision, whether it's a new business plan that they're thinking about, or they have a hunch, they heard from the floors, from the clinical leaders, that, okay, they're looking at complex patients nowadays, so the staff is tired and this and that. Do we have evidence to support what I'm hearing? That's what we get. And then we go back to them with whatever we have the answers to either prove it or say, this is what they are hearing and this is what it is. This is what actually it means. That's the point that we get to, answering some of the relevant questions, as I said. But the third point there is, this is all possible because, as I was saying earlier, because the trust has been already built, in the sense, the tool, that the way that we use 3Terra for that, I clearly remember this was one of those budget strategy discussions where the senior leadership is around the table. Our director is also there, and they look at our data, obviously, and they look at the CMI, and they're looking at the peers, and they look at the length of stay and things like that. And then questions came up where, the CMI and the length of stay, they don't make sense. For this example that I remember is about hip fracture. So what actually happened is, Ravi, for example, a director, he was able to go live while they were talking, bring the 3Terra tool up, go into that year and look at the hip fracture cases, obviously, and go into the case and show them that there was this 1 or 2 outliers that made all the difference. If you take them out, it's all there. So showing them live while they were having this conversation made all the difference. In an alternative timeline, it would have been, we'll take this back, we'll do all the analysis. We have access to the data from other sources, other tools that we have access to, and then we'll go back to them. By the time the question has moved on, it's gone, right? But this was kind of on the go, right? So that made some difference. So now that's where the trust was built. They looked up at Ravi and said, okay, now they know where to go and who to ask, because when you see the case in action, or what happened in action live on the screen, that made all the difference. Some of the leaders around the table are not, clinical, or they understand the Higgs, or they understand, what goes into the CMI and how it affects the flagged interventions, for example. So they were able to see it, and even the physician, the chief of physician, who was probably new at the time, could actually appreciate what they saw and what actually matters to them. So that was very effective right at the get-go. I just want to highlight that, how we stand. The next point about Matt that pointed out is the ability to work with 3Terra's team to come up with indicators or measures, views, or attributes that we are interested in. So, because of the location that we are in, right, Hamilton. So the question always comes up: what is the burden of the mental health and substance use patients, right? Because of the Hamilton area, and we are in downtown. So what's the burden? We keep hearing about the mental health and substance use population going up, and especially during the pandemic, it was a concern. When that question comes up, for sure, we can go back and look at the data that we have. We can use other tools, for example, IDS and things like that, and come up with a report. But there was no way to quickly give them an answer, especially when the president is going into a media call. And that was an example, again, I just pointed out. But we had already thought about something like this, and we took this with Matt, and Matt and his team worked on it for us. In the sense, we gave a list, and this is just a curated list that I just gave to Matt and said, okay, all the codes, F codes, and then a few Z codes here and there, and we just grouped them all, and then said, okay, if the main problem is one of these, categorize them, give them an attribute, call it mental health and substance use diagnosis subgroup. So we have that to pull into our reports that we can do on the web tool. So quickly we can run a report and understand the burden, for example. But currently, again, it's all a work in progress, right? So currently we have, the report that we have is looking at the main problem, but definitely once we have the access, and once we already do, and we're looking at the ways to get into the main problem and all the other problems. So if the main problem is a mental health, but the second problem is, say, alcohol abuse, so now you get to the details of it, you probably can use that for better understanding of the population that's coming to us in ED, for example. And then also some of these are related to, it's not an requirement to code the residential or poverty and homelessness, things like that. But again, that again brings to the highlights the fact of the education piece, where probably we should start collecting these, this information. If it's important for us as a facility, then we should have that as a strategy, as an organizational strategy to go ahead and start looking at those coded data. So that's basically from here. So now, yeah, so for that call, for example, that I was mentioning, we were able to give that number, and that was, again, back to that gaining trust and gaining that, demonstrating the expertise from our team was possible on that. So here we go. So next slide. Let me see if I can go down. Okay. So Matt and Jamie, can you quickly let me know if we are okay to show something live, or because of the privacy, we are not supposed to go there? Just a quick question, so I don't have to bring in the live tool.
I think we should stick with this slide.
Okay, perfect. Okay, just want to make sure. This one here is to look at, if I can just take you through the slide, that'll be useful. Where this is, what this is showing here is the HIG group. So that's the COPD that I've picked randomly. What I've done on the web tool, I've gone into the case. I've gone into this particular case, for example, and I've clicked on it. It's all on the web, so it's quick. There's no delay or lag. And then go into the case, and I looked at the case, and I saw a list of all the entire stay, the patient's journey, and who is the provider and everything else, the whole detail. So those who have used the tool, they've already seen it. They know what I'm talking about. And then you can actually go into it's one of the options that Trichara has done here, which is in our mind, and what we've used as part of the education and as part of the conversations with our leads when we're talking about the CMI and the impact on length of stay, or and the impact of length of stay or not, right? Both ways, to show them what is happening on the same case, but different weights and how it's impacting and all that. So when they see this in action, that's what we use for a live demo, for example. And here what we are showing is we can change all these options. So these are alternate scenarios. We can change the options to show to the audience how the weights have been calculated and how or each of these factors impact or influence the weight. So we can go through each of these and change it, and then on the fly, it changes the graph here. We can also go into the chart settings and change the length of stay, the actual length of stay, and show that, okay, if this patient ends up going to like 200 days in the hospital, your weights there would be like 150 or whatever that is. But that was shown. And the one thing that I have used personally a lot in my conversations with the physicians or clinical leads are the trim points. Now, it's very difficult to, as far as from my point of view, at least, it's difficult to, sometimes get a grip around at least from the physician's point of view, to what those things mean and how it impacts and all that. Here, what we can do is we can show them live that if this case, no matter what you do, you could, this patient stayed here for what? It looks like 8.5 days or 5 days, or what's the length of stay here? Something like that. And then 4 days or some. And then if the patient goes on and stays all the way to 20, that's your expected 20 days, it's not going to change or have any impact on your weight. The trim point is here. And then after that, you will get the per diem. Right. And then when you change some of these, like, for example, if you have a special care unit stay, when I change it to yes, and then all of these, that's how it changes. So back to that education piece to the physician team saying, hey, that's in your control. Some of the other things like the age or, how it's counted as a typical or not atypical case, or all those things, when we give you the data, it's all there, which probably is not important for you to know. This is what it is. You have to capture those flagged interventions. You have to capture those, ICU stays and things like that, and how it impacts and what is that. And then we take this for this particular case and convert that to dollars and show them how that impact would be. That's how we took it, and that's how we used this drill down piece specifically to talk about the impact or the link between length of stay and HIG. And sometimes the patients are, I can show you in the next slide, which is like it's a dementia case, and then that patient ends up staying here for way more and nothing happens. God came in through the ED, and that patient, for example, here, this case is one of those forensic patients who got admitted, but the state came in and got admitted, and nothing happened. Stayed here for that many months, and then that's your case. So, and that's again showing them live patient journey with what are the impacts on the Higgs or the weights and things like that is quite impactful. We also are looking at a project on looking at the drill downs to dementia cases, looking at the impact of that in our managing the length of stay, especially that sort of thing. So again, we've used that for our purposes to use a demo for those kind of purposes. Again, this is the law enforcement patient comes in, stays there, and nothing happens, that sort of thing. So the live demo of a case and going through the case, rather than giving a data, it was that conversation that we were able to have using the tool, which helped. I had kept one slide for demo, but I think we're not going to go there, right? So I think that's the end of my presentation.
Fantastic. Thank you so much for sharing, Sunil. So we're going to open up the chat for any questions. And while we're letting everyone gather their thoughts, pop things into the chat here, I just had one question for you. So if you were to provide one tip to a decision support team who are looking to get buy-in from hospital leadership, what would you suggest?
So if I can just jump in right now, our presentation, if you have noticed, that was the gist of it, right? So we have used 3Tera, for example, and any other tools for that matter. We also have, one thing I forgot to mention here is we also have Power BI, right? So we have used the backend access to go into, to build reports in Power BI, where we have tried to incorporate data from Dovetail as well, so which is Epic data, and the coded data, which is the 3Tera data, and we have created reports for ED and inpatient cases on Power BI. So again, back to that answer, how to get this. So again, the whole thing is about trust. So as I said, we are just in a unique position where we were able to gain that in terms of, because of the access that we have. As I said earlier, pointed out, Ravi is kind of an expert in, say, for example, it's the funding, information, the CMIs, the Higgs, the funding, and on the methodology, for example. So that's where, when all these conversations happen, Ravi is usually part of that. And that helps us because it's not like someone, brings us into the conversation at the tail end of it. So we are sometimes right at the beginning of it, right? So that helps. And then before the folks go around, ask other folks for data, and there are so many other, Digital Solutions is our team that looks after our pick. And there's a lot of people, like there's a huge army of folks there as an analyst and whatever. And then before they go all around and come back at the much end of the tail end of it, we're at the beginning of it. So that helps us. And gaining that trust by that effort that's been done is also helpful. And that's pretty much it. So if we can get that, whichever ways or means that we sometimes have to use, that's the way to do it, right? Because as far as what we always think here is that the leaders come from a point that they basically their a baseline is not to trust the data. That's what I feel. And I think data, the research shows that. I think I read somewhere that 92% of all the CEOs, for example, do not trust the big data and everything else, like what is presented to them. They have a mistrust of it. And that's because their reputation, their trustworthiness depends on this data, right? So they need to be very sure of what they see, because their trustworthiness, their leadership, basically everything else is at stake on this. So they have to run with this. So that trust begins right at the start, even from the leadership to trust the data, whatever they see. But that has to be with understanding, and a lot of empathy goes in there, understanding both ways, to understand from our side what is going on, and for them from their side to understand the challenges of their question, because it might not be easy to answer the question, right? So that both ways, understanding the empathy, being present around the table, including us right at the get-go, that sort of thing.
Awesome. Thank you so much, Sunil.
No problem.
I see a question in here from Sonia. I am going to divert this until the end of the session as it is a little bit more broad, and I think Matt can add some context to that towards the end. I'm now going to ask London Health Sciences to join us for their session to share their insights on ED analysis and performance.
Right, so I'm just going to share my screen, and Carly, if you want to kick things off and maybe introduce yourself and kind of the work that we've kind of done together. Yeah.
Sure. Hi, everyone. I am Carly Archer. I work at London Health Sciences Center in decision support. I am a consultant primarily focused with the mental health group and the emergency department, and a little bit on the side of access and flow in medicine as well. But for today's demonstration, I'll be focusing on the emergency department. So about a year and a half ago, there was a lot of leadership kind of changes, and we had some directors move into other areas, promotions. So we had some fresh new eyes in the emergency department. And with that came quite a few questions, more broad questions. Who are my patients? When are my wait times the highest? When am I seeing the most patients visit the emergency departments? And we have 3 sites. So when we do something for one site, the other site wants it, but a little bit different. And at that point in time, we were still very much create a report, PDF it, and email it. So every single time they wanted a different day or a different week or a different month or a different site or all the sites together, we would have to rerun the report and PDF it out. So that's when Jennifer McCallum reached out to Matt with some previous work that they had done together. And we started developing this idea of a report that showed these things very dynamically. We can pick the date ranges. Can we show different patient populations? And that's what we did. So Matt and myself and another consultant colleague of mine, we worked very closely to develop a report that would serve their needs. The awesome thing about my role is that I'm very embedded with the clinical staff and within the emergency department and the leadership. And I get to hear a lot of the conversations that spark a need for data. And sometimes when leadership from the emergency department asks for something, I know what they should be asking for, perhaps, and not what they actually are asking for. So Matt and I were able to create a report. We didn't have to burden the ED leadership with a lot of meetings and back and forth on different options. So it was pretty enlightening for the leadership when we did do the big reveal. We showed them how it works, and then we let them go off with it. We didn't look over their shoulder and tell them how to use it or when to use it. It was more, if they came to me with a problem, I would send the link and a couple screenshots and say, this is where you can see it on the 3Tera dashboard. And it was really nice. You can tell after a few months of them using it, their independence and confidence of them knowing who their patients are and the trends and when their ED is busy or why it's busy, the confidence in that and how they could speak to their colleagues without having to come to decision support for those questions was so apparent. And we have a few real life demonstrations that we're going to get into right now.
Yeah, absolutely. And so to kind of set the stage for this, as Carly mentioned, we've collaborated with LHSC for the past year plus to kind of come up with something that made the most sense. And what Carly said resonates with me is that you can't always ask the ED about what is it that they want, because they don't necessarily know. They know the questions that they might want to answer, but they don't necessarily know what information is important to get to that. So, as an example of something that we've built collaboratively with the hospital, all of this and that I'm going to show is available for any existing client hospital to try out in their environment. we've reached out to most of you and had discussions over the last few months, but if we haven't talked to you about it and you're interested in taking a look at this and trying it with your data, let me know afterwards. So Carly's ED group essentially had a couple of main questions that, I'm going to show examples of how they answer it themselves. And kind of the first use case was, we have a patient and something happened. They left without being seen. And we want to understand what happened around that time and why is it that they left. So we want to get some explanation about what's going on. The dashboard that I'm showing you, and I'm demonstrating this because we want to use demo data instead of actual hospital data here for obvious reasons. But what I'm showing you is a bunch of different ED performance metrics shown on a week basis on an hourly time frame. So every one of these things here is an hour by hour snapshot of what's going on in the ED at a given point in time. So if we had a patient that left without being seen around August the 30th, the team would go in here and they would start to take a look and hover over this chart. And the first chart is showing me how many patients left without being seen. And so I can hover over this and I can get some context. At 8 p.m., we had 5 patients leave without being seen. And at 9 p.m., we had 4. So immediately I can see this and say, this is not an isolated incident. This wasn't one patient. There's a cluster of patients that something's going on with, something's happening to. The next chart that we have, the second one here, the pink one, is showing us our ED census, essentially how many patients are in our ED at any given point in time. And again, I can hover over this and see, wow, our census is much higher than it was traditionally. The dotted black line, the comparison line here, is looking at the previous week or some sort of previous period. It could be last month, it could be last year, it could be prior to COVID, whatever you want. But it's looking at a comparison period to give you context. And to me, I look at it and I say, wow, we've got like another 50% more patients in the ED around this time. What's driving that? The third chart, the green chart, is looking at bed wait census. Essentially, how many no bed admits do we have? Patients that are admitted to the inpatient are waiting for an inpatient bed to become available. So they're still physically residing within the ED and taking up ED resources. And obviously I can see a spike here where our no bed admits are higher than they have been in the past and then higher than they traditionally are. But my eye is obviously drawn to what happened 24 hours earlier when the situation with no bed admits was much, much worse than it is kind of right now. And then I think the last thing, the blue chart at the very bottom, we want to tie these back oftentimes to how did this impact key metrics? How did this impact our wait times? So if we take a look at the blue chart, this is looking at the time to assessment. How long is it taking a patient to see a doctor from the time that they arrive in the ED? And I see spikes certainly around the time where we're seeing all these the left without being seen, but also in the previous days. So now we've got some context in terms of what's going on to be able to dig a little bit further. I guess the last thing I'll mention before I pass it back to Carly, if we want just broad trends of what happened last week or this week, the top right-hand side here and the information on the right gives me that. I can see how things have changed. So I can see that our ED volume is up 6%. I can see that the number of patients admitted to the hospital is up significantly, 15% compared to the week before. And that's because of an admit rate that is much higher. So obviously it's putting pressure on the ED and having the side effects that we're seeing here.
Yeah, and I will just hop back in and explain a little bit how I will use this with my clinical leadership team. So I like how Matt says it's gone up 15%, but to the clinical leadership, that doesn't click with them, right? We have to look at people. So we see 15 people, which is a unit. So there is a unit of inpatients in Emerge being serviced by the Emerge staff and doctors that would be much better and appropriately serviced on an inpatient unit, but they are being bedded in Emerge. A couple other points that I would look at from my mental health hat, maybe the bed wait census is high because there's a lot of mental health patients here. And you can see Matt just click that drop down there, and we have added in here just using CDIS codes, a mental health grouper. So we can remove the mental health population to see maybe if we remove that and that kind of specialty niche population, do things change at all?
Absolutely. The second use case that the team has kind of been looking at, and the big question that came up in initial conversations with the clinical leadership was, how does our department react when there's a surge in patients coming in to the ED? And I've got an interesting example that kind of demonstrates the type of analysis that's done. This is, again, a similar sort of analysis using some different ED metrics. And the first metric we would care about is the volume, incoming volume. So how many ED visits do we have on an hour-by-hour basis? And this time we're going to look at the Monday, October the 15th. And we can see that about noon on that Monday, we see a surge for a number of hours in the number of patients that are coming into our ED, where typically it might be 10 or so patients. We're up to 17, 18, 19 patients, which is like double what we're used to. So as you would expect, the second run chart here is looking at the census, and we see a spike in the census, right? We're going to have more patients in the ED for some period of time after an influx of new patients coming in. But what I find interesting is that look how long it takes for us to catch up to that volume, where typically there's this ebb and flow, and in this case represented by the dotted black line for the previous week. We don't get any relief from patients through in the ED until about the next day. It's about noon the next day by the time we catch up to where we would typically be. So it's had a significant impact from just a people in ED perspective. And then the last two charts are talking about things from, again, wait times perspectives. The blue chart is average length of stay. The green chart is time to PIA, time to see a doctor from when patient comes into the ED. And the ripple effect is obvious. In the hours after that, we see a significant impact to the length of stays. We see a significant impact to the time to PIA. The last thing I would note is this is kind of interesting, but at the same time, like in Ontario, the metric that people use for wait times performance isn't an average. ED pay for results in Ontario works upon a 90th percentile basis, which is, to summarize it, a measure of how many patients are missing their length of stay target. So I think a more meaningful way that people would want to drill into this would be to say, you know what, I'm interested in looking at a different metric here. And you've got the ability to do this, where the ED could come in here and say, you know what, I want to see how many patients missed our length of stay target. And if I update the chart with that, it's going to show me a pretty dramatic picture of how many patients over the course of these number of hours did we miss our length of stay target for. So where typically, we don't have any, or maybe have one patient that we're missing our length of stay target for, we're missing 9, 10, 15, 16 cases per hour. And the effect on our actual ED pay for results metrics is certainly going to be significant. So if we're summarizing, how did our ED respond to an influx of new patients over the course of a number of hours, I would say there's opportunity for improvement here, and the impact to our pay for results metrics were pretty significant.
Yeah, and just hopping again back to the clinical side of things, I look at this and I see this was probably the Monday after Thanksgiving, and are these influx of patients from the family gatherings? People are feeling sick, sore throats, those types of things, people without family physicians and don't really have a choice. So they come after work on the Monday to emerge. Those are the types of conversations I would have with my clinical leadership. And you can see that for this week, for the CTAS breakdown, they had a lot more level 4s, which prove that perhaps they weren't significant reasons, but it could be those simple coughs and colds that people are arriving to. Another comment I would probably have with my clinical leadership is that maybe there was some staffing issues that took us so long to get back to our target length of stay and target time to PIA. Maybe the portering department had a lot of sick calls, so they couldn't take our patients to different images, which delayed their discharge because it delayed their time to get seen by a different imaging department. So those are just a couple takeaways that I would bring to my clinical team.
Absolutely. So
And-
just to wrap up, I was going to say, I'd like to just loop in Jen and kind of get her thoughts on, from a hospital leadership perspective, what's kind of the key themes are for them that kind of made this important. If you've got anything kind of to add, Jenna, above and beyond what Carly was able to kind of speak to.
Sure, and thanks. Carly, you did a fantastic job. Okay, so when we had worked with DQA and Matt for many years, I think we were one of the last hospitals to actually sign up officially, but it's definitely, it's been a great partnership since we signed up. But what I would like to say is that we really needed more timely data for leaders to make decisions and also to learn about their business using the data. And when with ER pay for results, we found that every year there's money, you try to get money to help for coders or analysts or decision support. But things really, it was the same old with data quality. And did you trust the data, like Sunil had said earlier? So we really wanted to dig in. So what I would say is that was really the main driver for this. But when we dug in, and it was wonderful that Matt had already created a similar to ER pay for results dashboard. It was missing a few items, and we tweaked the indicators because they're publicly available. So we just added a little more specificity to the query and validated it to make sure it worked, and the look and feel was helpful for our folks. And I just would say that, you know, data quality is always a constraint. So for us trying to think it was data quality and reg sketch and physicians and all of this kind of thing, we dug in and we found out that we had programmers with historical reports who were here 10 years ago and nobody knew what was in the black box in our things. And it was a lot of different things. So it was really nice to look at and open up that black box to get an idea. And then the other thing that was the driver for me is the timeliness, currency of the data, because by the time we submit, so after the discharge month is done, then you have so many weeks to get it to CCO, then they have to package and publish it, send it back to us. And then our people, when they have time, have to make the new dashboard repetitively every month, PDF it and send it to everybody who can't click through it. So by that time, you're talking 6 to 8 weeks, depending on vacations and where the month falls. So by that, we looked at the opportunity to supplement. And we brought NACRS 1 in earlier, so there's a real timely. Now, it's not in the CAN published data, but NACRS 1, the trend is aligned, and our volumes are so high, it's easy to predict. So that was huge for us because we have a culture of it being perfect and published before you use it. But so that, I think the timeliness far outweighs waiting for perfection for sure. And the last point that I would say is we love the 3Terra, the way that the dashboard was built with Power BI, we could host it in our secure SharePoint environment. So it's very safe and seamless. So users are within their own SharePoint and they can click it. They don't even know they're linking into another vendor's report. And then as Carly said, there's dynamic drills. So they appreciate having it at their fingertips. They answer those quick staff questions such as, it's a busier September than last year. Oh no, do we need more staff? Or what's my holiday going to look at? They can look at, 5 years or however many years you have to be able to say, oh yeah, maybe we should staff up. I see the trend, or no, that's just an anomaly. And then there's also relevant summary level and provider level stats, choosing wisely indicators and physician scorecards for our medical leadership that we've never had before. And I think that's the value of bringing in the other feeds, the diagnostic feeds, and then the risk stratification they've done. So really, really helpful for leaders, and really pleased that we haven't dropped the ball and made it even better.
Fantastic. Thanks so much, Carly. Thanks so much, Jen. Jamie, did we have any questions?
We do have a few. So I just want to thank Carly for answering one about the types of data that are being integrated. I just want to jump back really briefly to Rod's question, because I'm sure this was one that a lot of people had. For this ED dashboard, was this a custom report build?
Good question. So initially it was a custom report build, but what we did is we ended up looking at it and taking feedback from others and generalizing it so that we can make it available for everybody to use. So initially it was kind of inspired by LHSC and us kind of working collaboratively together. But it was been generalized for everyone to be able to use.
Awesome. And then the second question, this is directed to Jen. Is DQA interfaced with Cerner for the ED data, or is this done through your BI tool?
So Matt, you might want to help me. So our Kai-Hi, we have a shadow database where it's saved in our data warehouse.
Absolutely.
And so it's all into, so Cerner goes into our 3M, and copies of that are in the warehouse, and this access is the copies on our warehouse, right?
That's
Every night.
exactly right. Yeah.
Okay.
And so we bring it in as level 1 data. You could integrate from the EDIS system if you want a more timely feed. We absolutely can do that. It's always kind of a trade-off of timeliness versus data accuracy, things like that. Okay. So with the few minutes we've got left, I think what I'd like to do is just provide an overview of where we're going with things with analytics at 3Terra. So let me just share a slide deck here. And I know we're kind of coming right up on time here, so if people have to leave, it's all good. But we'll be able to distribute the recording here for you to kind of catch up on this stuff if you're interested. As most of you know, the platform started as a health records tool, but now that it's used by over half the hospitals in the province for decision support reasons, most of the requests that we get are for things like reporting and dashboards and analytics. And we welcome this because this is what our background is. We've done data analysis for almost 20 years now in helping hospitals to integrate data, build data warehouses and reports. I mean, the question earlier about can you guys bring in case costing data? The answer is a resounding yes. Any data that needs to be brought in to supplement coded data to enable analysis can absolutely be done. The conventional approach to analytics has always been, let's build dashboards for users that are brimming with all kinds of invaluable information that are aimed at answering a wide variety of questions. And this is the way that we've always done it as well. But after presenting a lot of information to a lot of hospital leaders across the province over the past few years specifically, we came to a realization. And that realization was that the value that people get from analytics isn't in the volume of data or the complexity of data or even the robustness of the data. The audience has their aha moment through clear, concise tidbits of information that are effectively summarizing things for them and connecting the dots for them. So let me give an example. We provide every client hospital with a annual report which shows them how activity at the hospital has changed. And it will show you which patient populations are having more patients, are becoming more complex, which QBPs your complexity is changing for, things like that. And despite the fact that there's like 20 pages of rich information with a lot of graphs and detailed insights, the most impactful takeaway for everyone are these seemingly straightforward commentary bubbles that we include. And all this commentary is a summarization that's distilling down key insights into straightforward, like English sentences, but it removes the need for people to interpret complex visuals or have the kind of expertise in their minds to be able to understand what's going on when we're able to kind of tell them directly. So why this is kind of relevant is because what we've done with analytics is we've started to move away from traditional dashboards and towards something that's a little bit different. This is an a la carte menu of questions and specific themes that someone might want to explore. And each one of these things are something that we call data briefs. So you'll notice that each is meant to provide an answer to a specific question. It's not kind of a one size fits all, and that's intentional. So I want to give a couple of examples. And in order to do that, I'm going to put myself into the position of an ED manager, where I want to understand something about my department. So I'm able to come in here and look at all the different briefs that we have and say, oh, you know what? I'm interested in understanding how long patients are waiting in our ED, which is kind of a common theme when we're talking about length of stays and pay for results and all those sorts of things. When I select the brief that I'm interested in looking at, it'll allow me to provide some additional context. What wait times indicator do I want to analyze? And let's kind of keep with the time to physician assessment that we were talking about and kind of move on with that sort of analysis. And when I do this, it's going to give me a line chart on the right-hand side that shows me my month-over-month trend of 90th percentile time to PIA. But if I'm an ED manager, I want to know, what is it that I'm looking at? Why do I care? And what should I do next? And that's what this insights panel on the left-hand side is providing to us. It's providing in plain English sentences the context for what's here. So the fact that this graph is showing us monthly trends, so it's easy for me to see performance changes. The fact that there's a comparison line in here that is helping me to see what's changed since the last period, but also what are the limitations of this? So, you know, although this is good for showing me month over month what's happening, it's not going to tell me, am I going to meet my year-end target for time to PIA? That would be better answered through one of the items in the next steps here, which is a different brief that shows what is my year-end projection going to be. So when I click on that, that's going to take me into a different brief that's using the same information, but is answering a different question. Am I going to meet my year-end PIA target? And so this time, the chart on the right-hand side is giving me a cumulative. It's a year-to-date analysis of my time to PIA. And if I want to understand how likely am I going to hit my PIA, I can come in here, I can provide a target, I can ask the system to predict what's the likelihood of hitting that target. And it's going to project out for me the 2 remaining months that we have, and what is the probability that we're going to meet that target. There are more advanced use cases. If you want to understand why did I miss my target, there's a different brief that analyzes that. And this, we can get into it if you're interested in a discussion, but it's essentially showing us the distribution of patients and how many patients are we seeing quickly versus not quickly. And more importantly, what would I need to do to make this better? So as much as I've missed my target by 21 minutes, and that might seem pretty overwhelming, if we were to boil this down to what I would need to do proactively on an ongoing basis, it boils down to seeing 3 patients a day, 11 minutes quicker than you are right now. So giving actionable insights to the users. This is not the only way that you could look at it. Some of you as an analytical crowd would rightly say, listen, I want some more ability to drill down into this data to explore it on my own. You can still do that. If you want to do that, there's an advanced settings area on the right-hand side here where I can, for example, slice my time to PIA by shift or by triage level or by mental health cohort. And that allows me to, get an understanding of which population is driving changes. And it's not necessarily intuitive, like looking at this breakdown of day shift, which is the blue line, and night shift, which is our green line. You would intuitively think we should focus on fixing our time to PIA for the night shift. That's going to fix our time to PIA problem. But in fact, it's exactly the opposite that's true. But that's for another a brief to explain. I think although we've started with the emergency department analyzing things there, we're listening to the things that are most impactful for you and developing these things in priority order based on the feedback that we hear from people. So your problems the best. If there's something that is a burning issue for you, it's something that you've been working to solve, it's just a crazy idea that you'd like to bounce off of us, reach out, let us know, let's have a conversation. Our objective, just like with DQA, is to help to create valuable analytics that everybody can benefit from. To, like Carly said, and like Sunil said, help free up your time to engage stakeholders at a greater depth, to do more in-depth analytical work. And we can do that by kind of taking inspiration from ideas across the province so that everyone can benefit from that collective wisdom. Everything that I've shown here is going to be available within the next few weeks. So if you're an existing client, you'd like to see this and try it out with your own data, reach out to me afterwards. We'll set up a demo once it's deployed to your environment. If you're not currently using DQA, we can also show it to you with your data. Take a little bit more to kind of get it integrated, but we'd be happy to set it up and walk you through things as well. So I apologize for going a couple minutes over here, but I hope it was worthwhile. And this is something that we're really excited about in terms of where we're going and the future of analyzing data in Ontario. So Jamie, maybe I'll pass it back to you just to see if there are any kind of final questions that we'd like to address and go from there.
Awesome. Thanks so much for the teaser there, Matt. I'm sure everyone's very interested in it, and we're looking forward to hearing all of your feedback. There are a couple of questions from the chat that we just want to kind of tie up here because I know some people were really interested. Is there a way to add case costing data into the tool?
Yeah, it's a good question. I saw it come in a little bit earlier. You can integrate data into the tool very easily. And so every hospital integrates different data sets. Case costing is one that's certainly worth bringing in. It'll allow you to kind of compare, direct and indirect costs by different functional centers and things like that. And oftentimes something we've done in the past with hospitals is look at the cost of the case versus the weighting of the case and look for discrepancies there. I think the challenge with case costing is always the timeliness of that data. Most hospitals are costing at a quarterly basis at a most kind of frequent side of things. But it's certainly data that can be brought in, even if only to look at in a more retrospective basis. We can certainly do that.
Awesome. There is another question that I think would be worthwhile addressing. Is there a way to share the reports between hospitals? So the example here is share the ED report with us, and then we can use it with our data.
Yeah, absolutely. We can absolutely do that. We have don't have a library of reports that we've built for others, and it's getting harder and harder to manage, frankly, because a lot of hospitals are building stuff on their own. So where it used to be that we had an inventory of all the different reports that are available and could kind of distribute, it's turned into a more or less distributed version of things. But if there is a hospital using one report or developing one report, it's very easy for us to take that definition, deploy it to a different hospital's environment so that they can benefit from it as well. That's a great question.
Awesome. There are a few that we'll take offline. I think they require a little bit more in depth, but thank you so much, Matt.
Great.
Awesome. So I just wanted to end here by sharing the contact information for all of our presenters and saying that we sincerely appreciate everyone's time and attendance today. We understand that we went a little bit over, but we hope you found this valuable. To our speakers, Carly, Jen, and Sunil and Matt, thank you for sharing your experiences with the group. To ensure that future sessions continue to improve, a feedback survey will be sent by email this afternoon so we can ensure that the topics that we discuss in the future are important to all of you. Thank you so much.